This video is going to act as a wrap-up of the look that we've taken at historical osteopathic technique by using descriptions from specific authors, as well as some images where available. And what we were doing is attempting to choose a few techniques from specific authors in order to demonstrate what historical osteopathic technique was like. So how was it performed? What did it look like? How would you do it? Now, obviously, we didn't describe all the methods from all of these authors. However, I definitely did look at that so that I could choose methods that I thought were appropriate to share and would provide some insight. So there is a constraint process put on by me in order to choose the particular methods that I showed. However, I did look at most of the other methods. Obviously, there were some that I missed and authors that I missed, but I chose ones that I felt would be good examples. Now, what we're going to do is use that data, use the data available in that process and available in those texts to ask a few questions. All right, so those questions, if this works properly, were as follows. So we'll kind of run through those questions and then we'll go and answer them. So with that data that we collected, the first question is, were early osteopathic techniques based on small motions? In other words, did they use very small motions in very specific areas in order to perform treatment? Yes or no, right? And we'll have some examples of that. Did early osteopathic technique rely on minute palpation in the area of treatment? So was there palpation to sense the change very, very central to the methods, or was there maybe another way that they did it, or were there a multitude of ways that they did it? Were early osteopathic techniques easy on the practitioner, right? So was it hard work? Was it easy work? Is there any evidence to suggest that they attempted to solve if it was hard work, or things that they tried to do if they felt that it was hard work, that these methods were difficult? Did early osteopathic practitioners work in the region of the head? Yes or no? Fairly straightforward binary question. Do the heuristics that I use to describe how to generate osteopathic treatment apply to observable early osteopathic technique? So another way to phrase that question is, do the heuristics that I've used, if you go back and look through the YouTube channel that I have to describe how to perform assessment and treatment, do they describe early osteopathic technique well, such that not only does it describe it, but it can teach you how to generate it? So do the heuristics I use actually teach you how to generate osteopathic technique, as evidenced by the osteopathic technique that early practitioners used? So we're going to ask these questions and we're going to go through this hopefully in a fairly succinct way. So were early osteopathic techniques based on small motions? No, they weren't. Very, very broadly, early osteopathic techniques would best be described by the heuristic that I use for assessment, which is macro identifies micro. So a large motion is made up of smaller subcomponents, such that the small subcomponent that isn't working is identifiable and you can work on it. So they use large motions to treat small areas. They used all the moving structures to treat the non-moving structure. So very broadly, early osteopathic techniques were not small. They were not precise. They were large motions that would take care of the smaller problem if it was present. Right. So we look at something like Edith Ashmore's prone extension and side bending method, as you can see on the screen right here. The practitioner essentially had the patient go into what I'd call a Superman pose, and they would lift them beyond the plane of the table and pull them towards them. So whatever small thoracic vertebrae or small portion of thoracic vertebrae were not extending and side bending in the direction that was desired, this is how they would do it. They'd use the large motion. They would, off of the long lever by holding the arms, they'd use the heel of the hand as a short lever. So these were very large motions. These were macro motions to deal with micro problems. We see this in Edith Ashmore's upper thoracic side bending methodology, using the head as the long lever and the hand, the finger crossing the spinous process as a short lever, right? So large motions that would deal with the smaller problems contained within it. We see this with Dane Tasker creating double leg extension, so prone extension for the for the lumbar and low dorsal region or low thoracic region. Large motions to deal with smaller problems, macro motions to deal with micro problems. We see this in the dealing with kyphosis from Dane Tasker. So you put a knee in the patient's back, you use both arms. You're not seeing palpation particularly in the area of concern. You're just seeing this patient getting kneed in the back and being reefed on with both arms. This is a large motion to deal with a small problem. Right, so the next question, did early osteopathic technique rely on minute palpation in the area of treatment? Sometimes it would. You could have a hand that was being used as a fixed point, a hand as a monitoring point, but often what seems more evident or more regular is using the hand in the area of treatment as a short lever, sometimes as a wedge, but also as a short lever. Right? So a possible conclusion from this observation is that minute palpation is not central to early osteopathic technique, as available evidence doesn't support that. It's just not something that you actually see when you look at this. They used heavy wedges, heavy leverage. They would use long levers and short levers combined to create mixed leverage approaches. You didn't often see minute or specific palpation being central to their methods. It's just not something that you saw, right? Were early osteopathic techniques easy on the practitioner? Not really. Some maybe, so they were trying to use leverage to their advantage, but it often included heavy lifting on the part of the practitioner. So holding large portions of the patient, lifting both legs as an example. There was heavy leverage involved, but it did require heavy lifting from the practitioner. And another question that we can ask, where we don't necessarily have pictures of this, but if you are aware of osteopathic history, you may be aware of McManus tables. You may have seen beveled tables, right? So using the beveling of the table to increase the opportunity for leverage. Dr. Still talked about getting leverage off of door frames, using his knee. There is some evidence of Dr. Still, I believe Dr. Still saying don't use the straps. So what you would see in particular osteopathic offices is you'd see a hook, like a ring on the ceiling that straps would be strung through and attached to the patient to, instead of the practitioner directly lifting the patient, they'd use the strap as a pulley mechanism to use double leg leverage or things of the like. So it seems as though they used very heavy leverage and the techniques were not particularly easy on the practitioner. So there are ways that you can use leverage to your advantage where you can make it easier on yourself. It doesn't mean it will always be easy, but you can become more mechanically efficient using heavy leverage. Whereas the early practitioners, they were early on in the process. They were using heavy leverage and maybe hadn't figured out or had the insight as to how to make it easier with the methods they were choosing or patient positioning. So they chose to make devices such as osteopathic treatment chairs, right? Or the straps or the McManus table. They chose to use devices instead of just make different choices with how you relate to the patient and position the patient, right? So we see again, this heavy leverage, heavy lifting in the form of Dane Tasker doing double leg leverage, right? Again, heavy lifting. If you're holding both of the practitioner or the patient's arms and really you have to lean back, you're standing on one leg, even though his foot's probably supported on the rung of the stool there, you're off balance, you're doing a fair amount of heavy lifting, right? Did early osteopathic practitioners work in the region of the head? They absolutely did. Dr. Still is the one who spoke more about moving the bones, so moving the nasal bones, moving the jaw. Other practitioners spoke more about treating the terminals of the fifth, so the facial nerve specifically. So they tracked where the facial nerve came out of the skull, and they would treat the facial nerve or believe that they were treating the facial nerve, but both were done. So using the neurology or the functional anatomy describing where neurology is expected to be found is something that several practitioners spoke about. And then Dr. Still definitely talked about moving the bones of the face. Right, so here in pterygium, firmly push the nasal bones down towards the eye teeth, right? He is talking about moving the nasal bones on purpose, and we've shown this method or shown ways that this method may be done, right? Dr. Still, again, best way to reduce the size of the goiter, right? He talks about essentially going in, moving the jaw, pulling on the jaw, and then also going inside the mouth with a handkerchief to treat the buccinator muscle. Now, I would suggest that you don't have to go inside, you can treat it outside, but Dr. Still definitely talks about working in the region of the head, more so on the facial structure, but he did work in the head. Other practitioners, as I've noted, did talk about treating the terminals of the fifth. All right, now the heuristics that I described, contact is control, control is safety, relational motion, one thing stays still, one thing moves in relation to it. The table makes stable, less space between, or less table means I need to make the patient stable. Space between us is unstable. The anatomy should be exposed, free to move in the plane or planes required, preferably visible. Multisensory integration, keep your hands and your eyes on the prize, things of this nature. Assessment, macro identifies micro. All of these heuristics that I've used that you can go back and search through the YouTube channel to identify, do they describe how treatment is performed when you look at these early osteopathic practitioners? Well, they seem to pretty accurately describe the behavior of these early osteopathic practitioners with respect to the technical methods that we've observed and that I've read and haven't demonstrated, but it does seem to pretty accurately describe them. Because they describe these methods, how these methods are performed and how they work and why they work, at least on the mechanical side, maybe not necessarily on the physiological side, but on the actual physical performance of these methods. The follow-on prediction from the observation that the heuristics that I use describe this well is that the heuristics may effectively be used to guide teaching, learning, as well as generating osteopathic technical methods. So you can teach with these heuristics, you can learn with these heuristics, and these heuristics can guide how you generate an approach, a bespoke approach for the particular situation. One of the reasons that you'll have to adjust your methodologies when treating patients is because you are stable in some ways as a practitioner. You're probably the same size, the same strength for most of your osteopathic career. Your patients are highly variable. There are some patients that you, because of your size, can use on one patient, but not on many others. If it's a preferred method, you're going to have a hard time. Or if you have a preferred method that you use on everybody, and it's easy on one person and hard on everybody else, or hard on you to perform on everybody else, you're going to run into particular issues. So the ability to adjust, to use the concepts that drive how you generate the method, how the method is performed, can help you be more adaptable. So it can help teachers of osteopathy to teach these methods. It can help learners of osteopathy to have a frame with which to scaffold and learn these methods. So how do these methods work? How does this heuristic apply? And remembering a heuristic is a rule of thumb. Specifically, the way that I tend to use it comes from artificial intelligence, which differentiates between an algorithm. An algorithm is a set of steps that guarantees a solution, whereas a heuristic is a set of steps that generates possible solutions. The reason I think that that's more appropriate is because humans are variable, and generating possible solutions is more appropriate because humans are variable. They're not all the same. The same solution won't work for everybody, but you can generate a set of solutions and test them out within osteopathic hands-on care. So the heuristics that I utilize seem to predict how osteopathic technical methods are performed, especially when you look at the early practitioners that we've looked at, which would suggest that it's predictable that they would be good to use for teaching, for learning, and for generating methods as a full-time practitioner. So the nice thing about this project is that you can see how my heuristics apply to these old osteopathic techniques. You can see how they can be useful to adjust them. Some of the demonstrations that I've done show you how a particular method is difficult on the practitioner, so you can adjust it and use the same concept with a different patient position, and we describe why you would choose that different patient position. So these heuristics become fairly useful to not only understand and have a frame to understand the early osteopathic technique, but how to adjust it to your own benefit and to the benefit of the patient. So we're going to leave you with that. And thank you very much for watching this far. And hopefully you go and look at early osteopathic technique on your own, in your own way. And maybe you come to different conclusions than me, and maybe you come to the same conclusions, but either way, I think it's valuable to do that work.